So the last topic we are going to discuss today is the subcutaneous ICD. I'm going to talk about the need for the completely subcutaneous ICD. What is the evidence behind the subcutaneous ICD? Advantages, disadvantages, long-term outcomes, and future of ICD. You already have a little glimpse of future of ICD, because there is some overlap with respect to what we are seeing. And we also know what the problems we are seeing with the transvenous ICDs as well. So just you take back your little bit thought into the defibrillator evidence. If you really look at, I don't want to really burden you with this one, it's just a very, very busy slide. Don't worry about reading all those. Just to show that there are several trials showing evidence that the best therapy for a patient who is survivor of a cardiac arrest is clearly defibrillator. We all know that. And the patient who are at high risk for having sudden death in the form of low ejection fraction or patients who are inducible arrhythmias, they definitely seem to be helpful having a defibrillator. They're all in the class 1 section. Now, of course, the other things like channelopathies and other things also adds to this particular list. So the list is huge. That means to say that the denominator for implanting the defibrillators in this group of patients is a humongous load to the society. What it comes with us is the follow-up. What it comes with us is problems associated with this particular issue. If you look at the extracted leads due to infection, 58.6% of the patients, they're all extracted because of infection, and 29% because of the malfunction. This is a huge number of patients. So what it's telling us basically is the weakest link once again is the transvenous leads. Transvenous leads have been debated, they figured out, they tried to come up with a lot of insulation materials, combining silicon, polyurethane, multiple things. Despite doing all these things, the stress and strain on the constant activity of the heart contractility and also the crush fracture, what we see with the clavicular area, it's a chronic problem, it's a big problem or a huge problem. So if you look at the transvenous ICD complications, the risk of the transvenous lead related complication increases 2% per year. So what it tells you is, because if you are implanting a device, an younger patient, you are expecting a lot more complications because of the lead itself. So that we need to keep that in our mind. So the ICD, transvenous ICD related infections is 12% mortality at 1 year. It's not trivial when it comes to the pocket infection. When it comes to the endovascular infection, the mortality goes up. If there is an infective endocarditis, it is as high as 31% mortality at 1 year if they have endocarditis due to lead related problem. So this is not trivial. We need to keep that in mind. So the need for subcutaneous ICD. So transvenous ICD is the weakest link, the leads are the weakest link, and the higher chance for fracture. So the lead failure reaches 40% by 5 years based on the design or the patient characteristics. If you are talking in terms of an younger patient who is very active and who has hypertrophic cardiomyopathy, or ion channel abnormality, then there is a chance for a lead fracture is very high. Venous access issue, we often struggle with that. If one vein is closed, you go to there, other vein is closed, at some point you are struggling where to place all these leads. Then there's high risk of infection if the patients have indwelling catheters, for example, chemotherapy, or it could be in the form of dialysis. Perhaps some cosmetic in the pectoral region, in particularly long QT syndromes you particularly see in the young women. Then the transvenous ICD extraction associated risk is humongous. That's why the centers, they have specialized this. They try to do the extraction in a center where they have all the facilities, and despite that, the mortality is not trivial. Then the ICD shocks cause uneven distribution, the transvenous ICD shock. It causes electroporation, voltage gradients. We know that ICD shocks in MADIT RIT study showed it is very detrimental. That's very interesting concept. The differences between the SICD, I'll tell you about that. compared to the transvenous ICD when it comes to the damage that causes to the myocardium. So the demographics on these studies done for the SICD in this particular cohort was usually the primary cardiac disease non-ischemics were about 38.5%, ischemics were about 31.1%. And the whole host of other conditions where this the subcutaneous ICD was particularly used in this particular study. Not getting into the details of individual studies, these are the several studies which were performed for the SICD. The first one being Gus Bardi did the study, initial study, then subsequently several other studies have been done, and recently there was a presentation at the last Heart Rhythm Society meeting. I'll give you a little bit about the post marketing study on that particular study. So what did we learn from all these studies? So the lead related complication in SICD obviously is low because the lead is not inside the heart, the lead is outside. Then the system related failure are comparable, infection is comparable. So why do we worry about if the infection is comparable? What you are dealing is not endovascular infection here. It's is the extravascular infection, and we'll get to it when I actually show you that particular slide. So the inappropriate shocks, when it comes to IAS is showing inappropriate shocks, is very comparable between the two. You may think, I don't have an atrial lead, maybe the discrimination factor is a problem. It is not necessarily the case. In fact, they are very comparable. It can actually differentiate the supraventricular tachycardias very well, compared to the transvenous ICDs, mainly because these pickup almost looks like a regular ECG when you actually look at the electrogram. The biggest problem what we see with the SICD is the T wave oversensing. That is probably the major difference between the transvenous ICD. If you see the generations of the particular the subcutaneous ICD, the initial ICD was very thick. It is located here. Then the emblem, which is the most recent one, came on, which is MRI compatible, and the other one is the single chamber ICD, the transvenous ICD. They are very fairly comparable with respect to the thickness, although the CC wise is actually a little bit smaller compared to the SICD. Typically, how the ICD reads this particular electrogram is it uses a primary vector. The primary vector is the cathode is the body of the defibrillator can, and there is another pole here. It actually from here to here it is used as a primary, where it automatically switches if for some reason it cannot see the ventricular tachycardia in any particular situation into a secondary. So if that doesn't work, then it actually uses the alternate route. So there are 3 electrodes, one electrode here, second electrode here, and of course the defibrillator can here. So it uses these 3 different axes so that it can read the electrograms. So I will show you a little bit of the implantation technique, how it is being done. So identify the mid-sternal line, and then the 5th, 6th intercostal space, you mark that area, and then subxiphoid area you mark, and it is prepped in this area, and incision is made in the lateral, is anterior axillary to mid axillary line, and also here. Once you open, you actually place a suture, basically. I don't know, it is probably. Something wrong with the video.
It froze. It was frozen.
It's frozen. So basically, you suture that, keep the sutures in place, then hopefully it moves. I don't know, I can hasten this one, I'm not sure. Sorry for the delay. So basically what I'm trying to say is you make a little incision and then you use a tunneling tool. You actually place the tunneling tool connecting between these two, and then once that is done, then you connect the tunneling tool edge and pull the lead into this from here to here, and then you suture the lead there, and then you make another tunneling going up north right next to the parasternal location up to the second rib area. So in other words, this is previously it used to be a 3 incision technique where it was the lead was actually pulled to right next to the sternum. Now it is done in a 2 incision technique using a peelable sheath to place in the parasternal location. So you basically tunnel up right next to it, parallel to the sternum, very close to the sternum, keeping in place. Once the tunneling comes to that mark of the second rib area, you place that sheath, then take the tunneler out, and you basically slit it open and place this lead, push it inside that particular tunnel. On the other end, because it is so subcutaneous, you can actually hold at one end, and you can actually split this tunneler out. And once it is done, then you connect the ICD and basically place in the pocket and close the pocket. And most important, you need to be sutured, of course. The device need to be sutured so it doesn't migrate anything further. And the biggest difference, we know that defibrillation threshold testing has been largely abandoned in the transvenous ICDs in most of the places. We don't do it on a regular basis unless there is a high risk type of a patient. But for this particular still it is recommended to do the ICD defibrillation threshold testing just to make sure we can capture and deliver the appropriate energy for these patients. So how does it know it is ventricular tachycardia, the device? The template matching, similar to transvenous ICDs, it actually records in its brain this template matching of the sinus rhythm or the underlying rhythm and compares, and it uses multiple points, up to 41 points of the ventricular QRS complex to differentiate VT from the native rhythm. Then the far field mimics actually surface, like a surface ECG, you can actually see that. And there is 2 zones which are being usually programmed, which is the shock zone about 240 beats per minute, and is a conditional shock zone to pick up the SVTs at 170 to 240. It shocks 80 joules times 5 biphasic, can automatically reverse polarity if it is not successful. And it has got only 30 seconds worth of pacing capability after post shock, sometimes because you get a pause at 200 milliamperes, like a cutaneous pacemaker. So the recent thing is a smart pass filter which has been introduced, which is a software algorithm which helps reduce or minimize the T-wave oversensing. This seems to be valuable lately. So what it can do is, as you can see, the ventricular tachycardia looks like a regular ECG type of ventricular tachycardia, and the device actually shocks and converts here, right here, which is an appropriate one. In the inappropriate one, there is a T-wave oversensing. So it is counting, double counting, and it is delivering the energy there. So this is largely eliminated by this T-wave oversensing algorithm using the smart pass. So the advantages: no intravenous leads, venous preservation, no intracardiac leads, no pneumothorax, risk of infection is low, special advantages for previous device infection and hemodialysis patients, particularly patients who have immunosuppression like rheumatoid arthritis, other reasons. Then pocket infections with SICD can be majorly treated with antibiotics. In fact, there is a lot of studies, post-marketing studies, they didn't even remove the device. They're able to give antibiotics and suppress the infection without having to remove the device. And important thing, no need for fluoroscopy. So you can actually do without lead. That's another advantage. And it is cosmetic because it's hidden. You don't even see that where the device is located. And more people, they are actually doing between the serratus anterior and the latissimus dorsi. They actually keep the device so that it's hardly visible. So lack of apparent myocardial damage is seen with this patient because the shock is universally distributed. This is very interesting aspect compared to what we see with transvenous ICDs. So this may be an advantage with respect to shock-related problems, what we have seen in the MEDIT-RIT in patients with transvenous ICDs. The major limitations is patient need to be screened, and if you have a problem with T-wave oversensing, you cannot do that. Particularly, you can come across with hypertrophic cardiomyopathy type of patients and a very heavy weight patient. And the screening failures happens mostly because of the T-wave oversensing. And if the patients have myopotentials, oversensing, that may be a problem with causing the inappropriate shock. And the prolonged shock time is very scary for a lot of people, but although, a lot of times, they, it is actually handled very well. In all the studies, the patient, there's no big difference between the shock of 80 joules versus 31 joules, what we see. So the patient didn't have any huge difference. The atrial arrhythmia monitoring is not available at this time, but the SVT discrimination characteristics are very good. Pulse generator is larger and a little shorter life. It's about 7.3 years now, which is still not bad compared to what we see. And the costs currently at this point of time is high. I did put in actually one of the slides talking about the cost ratios, but I think probably in the interest of time I'll limit that. In the effortless registry, this was the registry which was done after the, these are both two IDE studies were involved, largest SICD database at that point of time of 985 patients. There is another cohort came, and it showed the freedom from complications caused by SICD was high, which is 97.9%, and inappropriate shock was very low. So these are the two things you are seeing majorly, and the other things, zero electrode failures, zero endovascular systemic infection. It's a very attractive figure when it comes to the treating these patients. This is the particular one which was presented in the last Heart Rhythm Society meeting, the subcutaneous post-approval study, and I will skip through quickly. In this particular, the difference between the effortless, which is the registry, compared to this, these were sicker patients. They have more heart failure and more diabetic patients. So that means to say what we are seeing is a more sicker type of individuals, very higher risk individuals. In other words, despite all these things, the complications were significantly low compared to all the studies done with other devices as well, transvenous ICD, and it seems to do very well overall. So in general, this SICD post-approval study was very, very favorable with respect to low complications, high efficacy, and in the patients with who need the defibrillator otherwise. And the differentiation for atrial fibrillation, discrimination factor was also very, very good, and so which led to the approval of the SICD as an indication as a class 2A in patients who are otherwise not good candidates for transvenous ICD. So you can actually do even without it. This was the cost analysis. The SICD costs are $22,000 in US, not sure the rest of the world, but is it cost effective? It is not available data, but if you look at the cost effectiveness of the transvenous ICDs, it is calculated over a period of time. It's the quality of life adjusted year is $100,000, and probably in my mind, if you calculate, it will be very similar. So there are advantages of having SICD. It eliminates needs for the vascular access and the possible implant without fluoroscopy, and all the lead-related problems are minimized, and endovascular infection rate is very low. The main difference is the mean DFT in the SICD was 36.6 joules as opposed to 11 joules with transvenous ICD. For the patients, they didn't feel hugely different. So overall, the first choice are the particularly pediatric population. They keep growing. You need to be thinking in terms of placing a defibrillator in the intravascular space is a huge problem. And the congenital heart disease patients, grown-up congenital heart disease patients, where there is no venous access, this seems to be very, very promising. Surgeons used to place patches on the surface and multiple things. It can be avoided now. Acquired stenosis of the central veins and the endocarditis previous, and endovascular leads associated problems. And patients who are waiting for cardiac transplantation are also very attractive, because you don't want to put in transvenous leads and end up having a lot of surgical related problems. And young patients seems to be extremely beneficial, mainly because we know that leads are a problem, transvenous leads, if the longer the time the patients have the transvenous leads. And other reasons, the ion channel disorders and other structurally normal heart patients having a need for a defibrillator where there is no pacing indication is a very attractive choice. Then when to avoid, when you screen that 7% of the patients what we screen usually turns out to be not the case, where they are not good candidates, you should not implant them. If they have bradycardia and they need a pacing, you should not implant. In the previously implanted unipolar pacing have any sensing issues, you should be thinking twice whether to implant this particular patient. And the systolic heart failure with who needs CRT, they are not the good candidates. And recurrent sustained monomorphic VT, where you need an ATP treatment, which may actually do well without having to shock, you can think about not doing these patients. And some anatomical characteristics where it is hard to implant in a pectus excavatum or something, those are the patients they are not ideal candidates. So it's basically the summary of the same thing. I don't want to belabor with that part. So the future is, you saw this slide earlier, these combining with a leadless pacemaker and this one, so you can actually communicate between the two using a Bluetooth technology, as well as having a pacing at the time when they need, whenever there is a bradycardia reasons, or you can even deliver the ATP, is probably one of the things which have been studied now. And this is the slide actually showed in the previous talk as well, the SICD in combination with CRT as well as defibrillator. So in summary, leads are the weakest link with transvenous ICDs. SICD is a good alternative for patients who don't need pacing and otherwise high risk for transvenous ICD. SICD implantation can be done under deep sedation without general anesthesia with experience. There are a lot of centers actually going away from doing general anesthesia with their deep sedation. They're capable of actually successfully doing this. This is something which is important to note, because the assumption is when you make a big pocket and you are tunneling, you need anesthesia. Not necessarily so. Leadless pacemakers in combination with SICD is extremely valuable in providing the additional benefits of ATP. With that, I conclude my talk. Thank you so much.